This is a case of routine cataract surgery done in our outpatient surgery center at Austin Eye Laser and Surgery Center. This is Dr. Shannon Wong, and I'm just going to narrate how I walk through a routine cataract surgical case. So this patient has just a regular cataract, reduced best corrected vision. They see about 20/50, and they've elected to have cataract surgery. So we give them a 10 milligram Valium tablet to relax them, and we just use eye drop anesthetic with 1% lidocaine drops. The patient's very comfortable, they're awake, they don't feel anything. All they're doing is looking up at the microscope light. Typical surgical time is about 8 minutes, and so they've had an anesthetic. We've filled the eye with a clear viscoelastic called OcuCoat, and I open the capsule to create the capsulorhexis with a bent needle cystotome. This video kind of incorporates the usual little tricks I use for every cataract surgical case. So the eye is filled with viscoelastic. The viscoelastic cannula is attached to the the cystotome is attached to the viscoelastic cannula. And anytime I see striations in the cornea, I go ahead and reinflate the anterior chamber with more OcuCoat. OcuCoat is also coating the surface epithelium of the cornea to enhance visualization of the structures in the eye. I make about a 5 millimeter capsulorhexis opening, and then I infuse balanced salt solution for my hydro dissection. The patient's very comfortable, and they're just instructed to look toward the light, which you can see the microscope light reflex in the camera. I'll tell them you're going to feel fluid and pressure, and then I'll go bevel down and insert my phaco tip. We use an AMO signature phaco machine attached to an Ellipse FX phaco handpiece. I use a divide and conquer technique combined with some phaco chopping. So I just make a central groove, and I usually try to just crack the cataract in half. I'll spin it 90 degrees using my second instrument, which is kind of a blunt chopper. And then I'll usually try to make another groove in the top half of the cataract, and I'll chop that top half into a quarter, and then I'll rotate the lens 90 degrees again, and then I'll try and move it another 90 degrees, and then crack this half into quarters as well. I kind of chopped it there just because it came easier, and then I just emulsify each of the four quadrants. The Ellipse FX phaco handpiece is very efficient and very powerful when we need to use the extra power for dense cataracts. This is kind of a medium cataract. So now we're going to take the last quadrant, and I usually place my second instrument behind the last quadrant to provide a barrier between the posterior capsule and my nuclear fragments. Now I've taken out the firm nuclear cataract portions. The outer softer cortex remains. I'm going to do my IA, so I'm going to go ahead and stromohydrate my paracentesis incision so I have better fluidics when I do my irrigation and aspiration. I use a silicone tipped INA instrument made by MST Microsurgical. It's very capsule friendly. I vacuum out the remaining cortex, including the subincisional cortex, and then I'll make sure to polish the posterior surface of the anterior capsule. I think this helps to reduce the rate of posterior capsule opacification months and years after cataract surgery, because we remove a lot of these lens epithelial cells that tend to grow on the back surface of the anterior capsule. And I'll also polish the posterior capsule with this silicone tip. The silicone tip is very capsule friendly. It reduces the rate of open posterior capsules encountered during cataract surgery. And it's also very good for manipulating and maneuvering a lens, because though it can kind of grip a lens and move it gently without scratching it, it's also very gentle on the posterior capsule. So here I'm just kind of cleaning up the posterior aspect of that anterior capsule. I have my INA handpiece in one hand, and I use a bottle of balanced salt solution in my left hand, and I'm serving as my own assistant by moistening my own cornea while my surgical technician is getting the instruments cleaned and ready to be re-sterilized so we can prepare for the next patient after this one. I refill the eye with OcuCoat, so I'm just using OcuCoat throughout the whole case. I usually use one syringe of OcuCoat, and that carries me the whole way from creation of the capsulorhexis to lubrication of the corneal epithelium to reinflating of the capsular bag to insert the lens. Here I use a smooth forceps to stabilize the eye. I insert my Bausch & Lomb soft port inserter through my 2.8 millimeter incision. I kind of use a double clutch technique to insert the monofocal Bausch & Lomb LI61AO, which has aspheric optics, into the capsular bag, and then I'll use my INA handpiece again to vacuum out the remaining viscoelastic. I try to spin the lens around to bring out any residual viscoelastic and any residual cortical material which may have remained in the fornices of the capsular bag. As you can see, it's very easy to spin the lens using this silicone tip. And then I go behind the implant to vacuum out the viscoelastic behind the implant, and I'm also removing any residual lens epithelial cells which have sequestered themselves between the posterior capsule and the lens implant. As you can see, I've got good 360-degree capture of the lens optic by the anterior capsule leaflets. So that's going to give me a more predictable, effective postoperative lens position. And then I'm going to stromal hydrate the 2.8 millimeter incision that was made. I'm going to stromal hydrate my paracentesis. I did not need to widen my incision throughout the whole operation. I'm going to make sure I've got my lens nice and centered. And then I'll do one more final stromal hydration. And that's how we do it. And we're all done. Thank you.